Anatomically, you can think of infectious pneumonia as lobar, bronchopneumonia, or interstitial. Lobar pneumonia is characterized by an intraalveolar exudate that leads to consolidation, potentially of an entire lung. Do you recall the most common organisms in the outpatient setting from micro? Strep pneumo and occasionally Klebsiella. Here's an example of a lobar pneumonia in the right lung, and it's in which lobe? Obviously, it's not in the right lower lobe because you can clearly see the right hemidiaphragm, so it is in the right upper or right middle. Well, it's a right middle because the whole area where the right upper lobe would be is clear. It's an example that the right middle lobar pneumonia that you may remember from the anatomy part of the respiratory lecture. So bronchopneumonia is characterized by acute inflammatory infiltrates from the bronchioles that extend into the adjacent alveoli. Typically, you see patchy infiltrates on chest x-ray that involves more than one lobe. Here's a histopathology image showing neutrophilic infiltration into the alveolar spaces. The infiltrates can also consolidate, and you can see it on a gross specimen. Here are some of the typical bugs that can cause bronchopneumonia. When do you expect to see staph pneumonia? You're typically going to find this as a complication of the flu or a viral pneumonia. You'll see it in IV drug users, hospitalized patients, old folks, and folks with chronic lung disease like COPD. Where do you find H. flu pneumonia? Usually in babies and young children. You can also see it in adults with COPD and other chronic lung disease. What about Klebsiella pneumonia? Think diabetics, alcoholics, and the elderly. Basically immunocompromised people. Remember, of course, the red currant jelly sputum that you might read about. I would also throw in Moraxella catarrhalis, which you can see in the elderly patients with COPD. Finally, it's also worth mentioning a few specific bronchopneumonia types, like aspiration pneumonia. What types of bugs would you expect to see in aspiration pneumonia? Since it's aspiration, you'll probably see gram-positive or gram-negative anaerobes from the mouth. The pneumonia will also be located in a more dependent segment of the lung. Then there's ventilator-associated pneumonia, or VAP, which is something we often see in intubated patients. This is a bronchopneumonia frequently caused by staph. It can also be caused by Pseudomonas aeruginosa. When you have a patient with a non-productive cough with fever and shortness of breath, you may want to think about an interstitial or atypical pneumonia. It's commonly caused by viruses, Mycoplasma, Legionella, and Chlamydia. Mycoplasma in particular tends to occur in what populations? Older children and young adults. As you can see here, on chest x-ray, you tend to see a diffuse patchy inflammation localized to the interstitial areas at the alveolar walls. You often hear this pneumonia referred to as a walking pneumonia. Why is it called a walking pneumonia? That's because it tends to have a more indolent course than other types of pneumonia. Legionella is a gram-negative rod that is associated with what? Aerosol from contaminated water sources, including cooling towers and large air conditioning systems. It causes, of course, Legionnaire's disease. What is the milder flu-like form called? It's called Pontiac fever. Legionnaire's can be deadly if not treated with a macrolide or a quinolone. Here's a silver stain of some lung tissue in someone with fatal Legionnaire's disease. The dark specks are all the Legionella pneumophila bacteria. Chlamydia pneumoniae is a common cause of community-acquired pneumonia. But what if I told you that a patient working at a pet store comes to you with signs of atypical pneumonia? Well, then you would probably think of psittacosis, caused by Chlamydia psittaci. Psittacosis is known as parrot fever, secondary transmission from pet birds like parrots, parakeets, and cockatiels. Lung abscesses are localized pus collections in the lung parenchyma. Lung abscesses are most often due to aspiration of GI anaerobes. You can also get it from bronchial obstruction, such as a lung cancer. In general, these folks are sick, malnourished, older, or debilitated in some way. The typical bugs are anaerobes, like Peptostreptococcus, Bacteroides, or Fusobacterium, and they typically respond to clindamycin. Aerobic bacteria, like Staph, Strep pyogenes, and Klebsiella, can also do this, especially in what setting? That would be a hospitalized patient with aspiration pneumonia, and here you would probably add a cephalosporin or ampicillin plus sulbactam. Finally, don't forget that fungi like Aspergillus and Candida can also do this, as well as parasites like Entamoeba histolytica. What might you expect to see on chest x-ray? An air fluid level. Let's do a flash quiz. What are the sequelae of lung cancer? Think of the mnemonic SPHERE: superior vena cava syndrome, Pancoast tumor, Horner syndrome, endocrine, recurrent laryngeal symptoms, and effusions. Speaking of effusions, pleural effusions are generally classified as transudative or exudative, depending on the underlying processes causing them. Transudates have a low protein content, or a serum to fluid protein ratio of less than 0.5, and a serum to fluid LDH ratio of less than 0.6 when you examine the pleural fluid. What's the physiologic mechanism for transudative pleural effusions? They happen when either the transcapillary pressure gradient is increased or the serum protein content, and thus the oncotic pressure, is decreased, such as in congestive heart failure, nephrotic syndrome, or hepatic cirrhosis. Exudates, on the other hand, have higher protein content, with a serum to fluid protein ratio of greater than 0.5 and a serum to fluid LDH ratio of greater than 0.6. What drives exudative pulmonary effusions? They occur as a result of processes that affect vascular or capillary permeability, such as malignancy, pneumonia, trauma, and collagen vascular disease. Exudative effusions typically need to be drained due to their increased risk of infection and empyema formation. One other type of exudative effusion worth mentioning is lymphatic effusion, or chylothorax. This is typically seen when the thoracic duct is damaged from trauma during cardiothoracic surgery or blocked by malignancy. When you tap the effusion, you typically get a milky white fluid that is high in triglycerides. As we discussed earlier, pneumothorax can present with classic absent breath sounds, hyperresonance, and decreased fremitus. Patients may also have some chest pain and shortness of breath. Usually these patients look very uncomfortable in the ER. Spontaneous pneumothorax typically occurs in tall, thin, young males who have these apical blebs that pop, but they're otherwise healthy. So why does this happen? Well, no one is sure, but it is thought to be related to increased shear forces in the apex during respiration, causing accumulation of air in the pleural space. There are some cases of familial pneumothorax as well, especially with Marfan syndrome, Ehlers-Danlos syndrome, and homocystinuria. Another type includes traumatic or iatrogenic pneumothorax. You can probably guess what's going on here. The causes here include any trauma or injury to the chest, like from a car accident or a knife wound. How can you, as the doctor or future doctor, also cause a pneumothorax? It can happen when you try to place a central line, biopsy the lung, or put a patient on mechanical ventilation. As we mentioned earlier, tension pneumothorax is one of those few respiratory emergencies where you often have to treat before the person gets to the emergency room, much less gets a chest x-ray. This usually starts as a traumatic or iatrogenic pneumothorax where the air enters the pleural cavity but can't exit because of the one-way valve mechanism. When too much air gets trapped, it pushes the mediastinal structures, like the trachea, to the other side. This usually starts as a traumatic or iatrogenic pneumothorax, where the air enters the pleural cavity but can't exit because of the one-way valve mechanism. When too much air gets trapped, it pushes the mediastinal structures, like the trachea, to the other side, which you can see here. These patients can be in severe respiratory distress that evolves to hypoxia, hypotension, and cardiovascular collapse, in addition to the absent breath sounds and hyperresonance. If the patient is in severe distress or looks unstable, what should you do next? You have to do a needle decompression immediately, even before you can confirm the diagnosis. So, if they ask you on the boards what to do, reach for the needle first and then get the chest x-ray later.